Okay, let's continue our conversation on the dental hygiene assessment. All right, let's go over dental biofilm and other soft deposits, and this is in chapter 15. During the examination of the teeth and their surrounding tissues, or soft tissues, I should say, hard and soft deposits are assessed. So we're going in there, we're taking a plaque indice, which is covered in chapter 23, and we're going to check and see where the patient is at with that. And the reason this is so important is because dental biofilm is the primary risk factor for gingivitis, inflammatory periodontal disease, and dental caries. Okay, let me repeat that again. It is the primary risk factor for gingivitis, periodontal disease, inflammatory periodontal disease, I should say, and dental caries. Okay? So I want you to know that the assessment is a really important aspect or integral aspect of the dental hygiene diagnosis. On the basis of our findings of the assessment, we're going to customize a care plan for each patient, okay? So please review all of the keywords found in box 15-1 and know that soft deposits are acquired pellicle, dental biofilm, material alba, and food debris. Now, hard deposits are our calcified deposits on the teeth, such as dental calculus, okay? So there is just a little bit of difference between biofilm, which is a soft deposit, biofilm, acquired pellicle, materia alba, food debris, those are all soft, okay? But when we start talking about those harder calcified areas, those are our hard deposits. And you need to know the difference between those when you get into clinic. So a comparison of types of dental deposits with their descriptions can also be found in table 15-1. Okay, so as I already stated, we have our soft, non-mineralized deposits, which is acquired pellicle. That's kind of the cuticle, okay? Then we have dental biofilm. We have materia alba and food debris. Then we have our hard and mineralized deposits, which is our dental calculus. And here, I believe this is from an older book, but I believe now it's table 15-1, and you can see the description. Do know this, do spend a little time reviewing this chart, because you will need to know that. This is very important. This is what we're removing, so we need to know what's significant about its location, what bacteria are you going to see in each category. So make sure you know also like what alters it, okay? Okay, let's talk about acquired pellicle now. Acquired pellicle is a really thin acellular film that is formed by proteins, carbohydrates, and lipids. So I always think of it as, you know, what are the three main categories we look at on a food jar, right? We're looking for protein, carbohydrates, and fat, right? So those are the three things that are in acquired pellicle, or what forms it. So you can imagine that this is going to come on very quickly, right? Because we're constantly introducing those things into our oral cavity. Now it forms over exposed tooth surfaces and restorations and calculus, and it's very thin. So it is actually 100 to 1,000 nanometers, and it depends where it's at. So what makes one area 100 nanometers and one area 1,000 nanometers? Well, that is depending on the location in the mouth. So what you're going to see is it's going to be thickest at the gingival margin. And why would that be? That is because when you're chewing and speaking and things are kind of moving around in the mouth, what part of the tooth gets used the most? It's going to be the lower third or 2/3 of the tooth, right? So that's what is going to make it so much more thick at that gingival margin, just because it's undisturbed. Okay. Now, it does begin, acquired pellicle does begin to form within just minutes after eruption, or all other soft and hard deposits have been removed from the tooth surface, such as our polishing, right, or our air polishing. The pellicle begins to form and is fully formed within 30 to 90 minutes. Okay, so that's that nice feeling that everybody feels right after their teeth have been polished, what they actually think is the cleaning, but it's not. We need acquired pellicle. Acquired pellicle, I always think of as a double-sided tape. One side is adhering to the tooth, and one side is adhering to all the substances that it's being exposed to from the oral cavity. Okay. Now, its composition is primarily glycoproteins that are selectively absorbed by the hydroxyapatite of the tooth surface. That's that matrix that we talked about back in embryology and histology. You probably talked about it a little bit in dental anatomy also. Okay. So it's primarily composed of the glycoproteins from the saliva that are selectively absorbed. Okay, and it allows for the bacteria to attach. So again, that is our double-sided tape. One side is adhering to the tooth, and now the other side is going to adhere to the bacteria in the oral cavity. Okay. So its components are derived from the saliva of the oral mucosa, from the saliva and the oral mucosal cells. Also the gingival crevicular fluid, that fluid in that crevice in the margin on our sulcus, okay? The gingival crevicular fluid and microorganisms. Okay, so we have a few different types of acquired pellicle, and one is supragingival pellicle, and supragingival pellicle is clear, translucent, insoluble, and not readily visible until a disclosing agent has been applied. Okay, so that's our supragingival unstained. Or when I say supragingival, we also have surface, because you can see it, surface stained, and then subsurface would be subgingival. Okay, so pellicle can take on staining through extrinsic means, and they become grades of brown and gray, other colors. I've seen orange and green. We don't want to talk about that, but no, we will talk about it later on. When stained with disclosing solution, pellicle appears thin with just a really pale staining that consists with the thicker, darker staining of the biofilm. Okay, so when you've had your teeth disclosed, you'll notice that everything's just kind of a pale pink, but then those darker pink areas stick out to you. That's the biofilm. The acquired pellicle is the pale pink. Okay. Then we have subgingival or subsurface pellicle, and this is continuous with the supragingival pellicle, and it continues to migrate towards the apex and can become embedded in the tooth structure, particularly when the tooth structure is partially demineralized or rough. Okay, so important for you to know that subgingival pellicle can really be embedded into the tooth surface, especially when it's demineralized. Okay, so acquired pellicle plays a really important role in the health of the oral environment. It plays a protective role, a lubricating role. It becomes a nidus for bacteria, and it also aids in the attachment of calculus. So as a protection, it becomes a barrier against acid, so it helps reduce the caries risk. Then it also lubricates and keeps the teeth nice and moist so that when you're speaking and eating, it's allowing you to do so without everything sticking to your teeth. Now, on the other side, there are a couple negatives too, and that is that it becomes a nidus for bacteria, meaning it's helping to participate in the biofilm formation by helping it adhere to the enamel structure. It also is one of the modes for calculus attachment. Now, removal of pellicle is not super resilient to withstand rigorous patient oral health care or home care. So extrinsic factors that may interfere with pellicle formation and maturation include abrasive toothpaste, whitening products, and an intake of a lot of acidic foods or beverages. Okay, so we do need this acquired pellicle on there, and we don't want to remove it constantly. We don't want to disturb it that much. Okay, so we talked about the acquired pellicle, and that's our double-sided tape. One side is going to be attached to the tooth. Now the other side is going to start becoming that nidus for bacteria. Okay, and that bacteria, those microorganisms are now colonizing, and it's creating a biofilm. And I always say a biofilm is much like if you take a rock out of a river and it's kind of got that slimy layer on it. That is biofilm. Okay, it's not super easy to remove all the times. It's structured. They used to just call it plaque, and we still call our indices plaque indices. But we found that it's a little more complex than a plaque, okay? I won't get too science geeky on you here, but there is a difference. Plaque is very simple. They don't communicate with each other, where the biofilm is going to communicate with each other. They're going to cause a party in there, okay? They're going to keep having more and more join them. They can communicate. Send a message out that, hey, this is a susceptible host. Let's party, okay? So it is a dynamic, structured community of microorganisms encapsulated in a single produced extracellular polymeric substance, so EPS, and they form a matrix around microcolonies. So these are colonies. Again, it's not a plaque. The matrix is composed of polysaccharides, proteins, and other compounds. It acts to protect the biofilm from the host's immune system and from antimicrobial and antibiotic agents. So let me say that again. It acts to protect the biofilm from the host immune system and from antimicrobial and antibiotic agents. So very smart. The microcolonies are separated by a network of open water channels that supply nutrients deep within the biofilm community. All right, I mean, this is called a community for a reason, okay? They are very tricky. They know how to survive and help each other survive. So the three-dimensional structure of biofilms enhances their ability to communicate with each other and adapt and respond to their environment. All right? So you're at the party, you're kind of observing, seeing what everybody's doing, and you're going to try to fit in and find a way to mold yourself to that community. Okay? And they're telling you, hey, if you do this, you're going to fit in this community just fine. All right? Biofilm communities also form on oral mucosa, surfaces of the tongue, the tonsils. Their presence, especially on the tongue and tonsils, may contribute to malodor. There are over 700 distinct bacterial species found in the oral cavity along with a variety of other microorganisms, including viruses, protozoa, and yeast. Morphologic forms of bacteria that are found within biofilms you can find in figure 15-1, and I believe we have that on our next slide here. All right, here we go. So you can see how they're changing, and we're going to talk about the stages of change here coming up. All right, so stages in biofilm formation. Stage 1, the biofilm formation begins with the initial attachment of planktonic bacteria. Okay, so I want you to know that this does not occur randomly. It involves a series of complex interactions. Okay, so biofilm formation begins with the initial attachment of planktonic bacterial cells to the pellicle of the tooth, or on the tooth, I should say, by the way of bacteria's interaction with the pellicle. Okay, so that's a physicochemical hookup. Okay, initially, the adherent cells are not yet committed to the process. And during the stages of adhesion, the process is reversible. Okay, so we can reverse this. When the cells are disrupted, such as brushing and flossing, they can be dislodged from the surface to resume the planktonic life and either be eliminated or begin formation somewhere else. Okay, so hopefully they're being eliminated, right? Then in stage 2, that's the bacterial multiplication and colonization, okay? If the planktonic microorganisms are not removed through brushing and flossing, they will attach themselves a little more permanently using cell adhesion structures such as the fimbria, ampullae, flagellus, and adhesion proteins. The microcolonies start to multiply in layers, and they're going to grow upward and outward, okay, creating the three-dimensional aspect of biofilm features. So I more want to say they're gonna grow apical and outward, okay, and that's because you're chewing and eating. So generally, you're not going to get it in that, that upper 2/3 of the tooth is going to be fairly clean. It's also growing outward. I want you to think about that. With increased size, colonies produce extracellular polymeric substance, EPS, to firmly attach in an irreversible manner. So rough surfaces will result in a more rapid, irreversible attachment. So think of margins where the crown and a tooth meet, or maybe they have a rough filling in there. The tooth surface is maybe demineralized and a little bit rough, so it's going to attach there a little more easily. So the organisms that colonize within the first few hours are primarily, and you absolutely need to know this, please write this down when I say it. The microorganisms that colonize within the first few hours are primarily gram-positive cocci and rods. Okay, that's certain to be on your boards. Now, stage 3, matrix formation, the bacteria within the aggregate of cells continues to secrete EPS as bacteria multiply to form a matrix. The components of the EPS are the polysaccharides, glucans, fructans, and levins produced by certain bacteria within the community, and from dietary sucrose, or sugars, right? The polysaccharides are sticky and cement the biofilm more firmly to the teeth, okay? So those polysaccharides are playing a huge role in the adherence of the bad bacteria, our biofilm, adhering to the tooth. The EPS matrix anchors the bacteria together, which increases the adherence to the tooth and other structures. The bacteria community is protected and continues to grow. The adhesion and stickiness of the EPS matrix makes biofilm disruption challenging. So ineffective toothbrushing will not adequately disrupt biofilm for this reason. So it needs to be done properly. There is a technique for brushing. There is a technique for flossing. Okay? The biofilm structure enhances its ability to survive and thrive and adapt to ever-changing environments within the oral cavity, both supragingivally and subgingivally. And we're kind of dividing things up here, supragingivally and subgingivally, because where does that disease, that periodontal disease begin? Subgingivally, right? Where does caries begin? Supragingivally. So you're going to be talking about a little bit different bacteria that are in each of those areas. All right, so biofilm growth. The stage is characterized by further development of biofilm architecture that enhances a cell-to-cell communication process. So again, they are communicating. This is activated by a specific gene located on the surface of the bacterial cell walls within the biofilm. The mass and thickness of biofilm increases as a result of bacterial multiplication. Now, if this is left undisturbed, the bacteria is going to continue to adhere to the biofilm community and surrounding surfaces. So, ignoring it isn't going to make it go away. It is just going to keep multiplying and multiplying and multiplying. And as it's doing that, now we're getting a more mature colony of bacteria. And these release the planktonic cells to spread and colonize other areas within the oral cavity. The bacteria can disperse as single cells or clumps of cells. So with all of this, now I want you to think, what's happening in your mouth, right? Where are all those bacteria located? How are we going to remove them and prevent the spread? And these little single cells can go to the tongue, they can go to the oral mucosa, they can go to another tooth surface, they can go to a restoration, to a denture, to a partial. So these can just kind of go anywhere they want, all right? And as they break up and they settle in these other areas, they're going to find a home, and it's just going to continue to spread. All right, so we talked about the stage 1 formation. Not going to keep going over it here. Okay, so here's our stages on a nice picture here. Salivary proteins forming the pellicle layer on top of the enamel. And then we have the salivary microorganisms, and they're starting to adhere to that pellicle layer. And then it just continues to grow outward and upward. Again, stage 4, we're going to get that cell-to-cell communication, and this is known as quorum sensing. Biofilm increases in mass and thickness in stage 4. Stage 5, it is fully mature, and it's starting to release more cells and spread them to other areas of the oral cavity. All right, so dental plaque biofilm formation. You can see how it becomes mature, and then it starts to break off and release more, and it starts all over again in another area. All right, here's a location. You do need to know this. So location, supragingivally, is going to be anything coronal to the margin of the free gingiva. Subgingival, of course, is going to be anything under the gingiva. The origin for the supragingival is going to be this salivary glycoprotein. Protein forms the pellicle, where the subgingival is just the downward growth of the supragingival biofilm. And the distribution This on the supragingival, it starts on proximal surfaces or other protected areas. It's heaviest on the areas not cleaned daily by the patient. It's also on the cervical third because that is often missed when brushing. Also, when eating, if people aren't brushing, they're eating, keeping that upper 2/3 somewhat clean. Lingual and mandibular molars, proximal surfaces, and pit and fissure biofilm. And then for subgingival, you're going to see a shallow pocket. It's going to be similar to the supragingival biofilm. If left undisturbed, held in the pocket wall, attached biofilm then starts to cover calculus, and unattached biofilm extends to the periodontal attachment. I'll let you guys finish reading the rest of this. Okay, so here's another area where we are differentiating the supra and the sub as far as shape and size, the structure of it, the microorganisms. You are responsible to know all of this, okay? Let's go down to the etiology here of gingivitis. The supra is going to cause the gingivitis, supragingival calc, and dental caries, where the sub is going to cause, it's the etiology of gingivitis, periodontal infections, and subgingival calculus. All right, changes in microbiofilm, of biofilm microorganisms. Biofilm consists of a complex mixture of microorganisms that occur primarily as microcolonies. Populations and density is very high, and it increases as biofilm ages. Caries and gingivitis risks as number of microorganisms increase. So caries and gingivitis, the incidence and the risk increases as the number of microorganisms increase. When personal oral hygiene is discontinued, the number of bacteria increases rapidly, almost exponentially, okay? Because they just keep multiplying. The more there are to multiply, right? So they just keep going. That's why daily biofilm removal is so important. Okay, so here's the day-to-day biofilm as it progresses. Okay, so you're going to see epithelial cells in a few cocci. That's a pretty clean mouth. Okay, and then you don't clean for a couple days, you're going to start to see masses. You're going to start to see masses of cocci and short rods. Then as we progress to days 4 through 7 without being cleaned, you're going to see more filamentous bacteria and leukocytes and fusobacteria. And then in 1 to 2 weeks, you're going to start seeing those, they start to become more gram-positive, and you're going to see the spirochetes and the vibrios, okay? And then acute gingivitis appears in about 2 to 3 weeks. And this is if no cleaning has occurred, okay? And remember, this is an average, so it's going to vary from person to person, but pretty effective when you see this to know exactly what's happening. All right, so dental biofilm consists of a complex mixture of microorganisms and microcolonies. We've talked about that. The microbial density is very high and increases as biofilm ages and matures. So in days 1 to 2, you are going to see early biofilm that consists primarily of that gram-positive cocci, okay? Streptococci, which dominates the bacterial population, includes Streptococcus mutans and Streptococcus sanguis. I never know how to say that. Sanguis, okay? Then we move on to days 2 through 4, and this is without removal, okay? The cocci still dominate, and increasing numbers of gram-positive filamentous form in slender rods join the surface of the cocci colonies. People who form biofilm slowly will exhibit more cocci and fewer filamentous forms. So that's always kind of interesting, right? Gradually, the filamentous form grows into the cocci layers and replaces many of the cocci. Now, days 4 to 7 without removal. Filaments begin to increase in number, and a mixed flora appears comprised of rods, filamentous form, and fusobacteria. As the biofilm spreads coronally, newer and younger biofilm is primarily cocco. Now, days 7 to 14. Again, no, this biofilm hasn't been removed. Now it's going to continue to progress to vibrios and spirochetes. They start to appear, and the number of white blood cells start to increase. During this time, inflammation develops and can be observed in the gingival tissues. So days 7 to 14, we're going to see signs of inflammation. We're going to be able to observe signs of inflammation. Okay. Now, days 14 to 21. In older biofilm, vibrios and spirochetes are prevalent with fewer cocci and filamentous forms. Its densely packed filamentous microorganisms can arrange themselves perpendicular to the tooth surface in a palisade. As biofilm matures and thickens, more gram-negative anaerobic organisms appear, which are protected by the biofilm architecture and environment. Gingivitis is now evident clinically. Okay, so let's continue talking about that 14 to 21 day period, that 2 to 3 weeks. Gingivitis does start to develop, as you saw on the previous slide, in that 2 to 3 weeks when biofilm is left undisturbed on the tooth surface. Most gingivitis is reversible with mechanical biofilm disruption. Healthy gingiva can return within just a few days. An experimental gingivitis program to demonstrate the effects of biofilm can be conducted, and you can see that they are outlined in box 15-2. And I think these pages might be wrong on here. I think they're from the old book, but the program demonstrates the effects of biofilm. So withhold all biofilm control measures for 3 weeks, and then repeat clinical observations using indices. So you'll check and see how much biofilm is around there. And then you reinstate the oral hygiene after final recordings and make daily observations relating to gingivitis. I don't like this. I would never suggest somebody keep biofilm in their mouth for a little test, but you could, I guess. Okay, so indices in Wilkins chapter 3, they are an expression of clinical observations, and what they do is they give it a numeric value. So your plaque index says that you have 50% plaque in your mouth. So plaque is on 50% of the surfaces, okay? Describes a status for individuals or groups being measured, and it standardizes the method of interpretation and provides objective data. So objective means we are seeing it, right? As a clinician, we are seeing it, not the patient reporting it. That is subjective. Objective is that we're seeing it, okay? So here's some examples of plaque control indices, and we do a version of the OHIS in our clinic. So you will be checking 6 teeth, and so there's 24 surfaces. If they have 12 surfaces that have plaque on it, their score is 50%. Okay, and you can see the OHIS form on the right-hand side here. They're just checking 6 areas. Okay, so supragingival and subgingival dental biofilm. Source: a subgingival biofilm results from the apical proliferation or growth of microorganisms from supragingival biofilm. Early stages of gingivitis and periodontitis and supragingival biofilm is a strong influence on the accumulation and pathogenic features of subgingival biofilm. Supragingival biofilm has a strong influence on subgingival biofilm. All right, the microorganisms, flora of subgingival biofilm differs from that of a supragingival biofilm. So subgingival includes more of the anaerobic. What does anaerobic mean? It means they don't like oxygen, right? So you think about where they're going. It's easy to remember because they are not as exposed to oxygen. They're hiding in the cave of the sulcus or the gingival or the periodontal pocket. Okay, so it's going to have more anaerobic and motile organisms, and they are predominantly gram negative. So they're going below the gum, negative, below. Okay, 6 subgingival bacteria species with aging biofilm. All right, and here's our subgingival species complex. And so you do need to know a lot of these, especially those in the red circle. The let me see, I'm going to check and see if my pen is going to work today. We'll see. I'll use black here. There we go. All right, need to know these guys right here. Okay, and then our actinomyces species also are definitely important to know. So those are the ones that kind of the boards really wants you to know about, that these are our subgingival species complex. So organization of subgingival biofilm: tooth surface, attached biofilm. Over the pellicle, it is a layer of densely packed organisms. Again, we're talking about subgingival biofilm. Biofilm in this area is associated with calculus, root caries, and root resorption. So just know calculus and then anything that says root on it, right? Unattached biofilm: between 2 layers of attached are many planktonic motile gram-negative organisms. So they're kind of the freeloading biofilm is the planktonic biofilm. Contains many white blood cells because remember, this is the biofilm that has already formed supragingivally. So we know that it has the bacteria of that 3-week, that 21-day bacteria, and that is what is migrating into the sulcus. The epithelium-associated biofilm is loosely attached to the pocket of the epithelium and are gram-negative. Okay, so continuing the organization of subgingival biofilm, the epithelium-associated biofilm continued. It is loosely attached to the pocket of the epithelium, and they are gram-negative. Often consisting of white blood cells and many virulent pathogenic organisms. So in the initial layer, you're going to see the actinomyces that give rise to the intermediate layer. composed of the spindle-shaped cells. Okay, so know that the, actually I think it's actinomyces, sorry about that, microorganisms. And they're kind of our first layer that are now becoming spindles, and they kind of turn into that T. forsythia. And those are kind of the ones that the boards really wants you to know. And you'll get a little bit more of this in perio. All right, so here's the bacterial invasion. Diagram of a periodontal pocket shows the bacteria of attached and unattached biofilm bacteria within the pocket epithelium, in the connective tissue, and on the surface of the bone. So you can see how these bacteria are penetrating through the tissue. You know, once it swells, it becomes more porous, right? So as that bacteria stays in there, it becomes, once those white blood cells are coming to the area, they are expanding the tissue, making it more porous and easier for all these bacteria to invade. And then they go down here to the bone and they start destroying this bone. And that's what eventually, that's when it becomes periodontal disease, when you start to see permanent loss. You can't regenerate this bone. You can't give more attachment to a tooth. Sometimes you can, but without the bone there to support it, it's temporary. The composition of dental biofilm, it is composed of microorganisms and intermicrobial matrix. It is about 20% of the biofilm that are organic and inorganic solids, and then the other 80% is water. The composition does differ among individuals and among tooth surfaces. So we have our inorganic element, and that is calcium phosphorus. Notice how that's in purple. You need to know that. Concentration of calcium, phosphorus, magnesium are more concentrated in the biofilm than in saliva. The saliva then transports the minerals during the mineralization and demineralization process. Then we have fluoride, and we all know that fluoride has so many great benefits, but the concentration of fluoride in biofilm is higher in the presence of fluoridated water and increases following professional topical application of fluoride and the use of fluoride-containing dentifrice and mouth rinses. So you want to make sure that they are using something approved by the ADA, because that will have a sufficient amount of fluoride in it. All right, our organic compounds include carbohydrates and proteins. And our carbohydrates include the glucans and fructans or leavens from the dietary sucrose, and they contribute to the adherence of the microorganisms to each other and to the tooth. The proteins, supragingival biofilm protein is derived from saliva, but subgingival biofilm proteins are derived from the gingival crevicular fluids. So that's that fluid that's in the sulcus or the pocket of the tooth. Okay, so distribution, clinical aspects, the location, supragingival biofilm is coronal to the gingival margin. Gingival biofilm is on the external surface of the oral epithelium and attached gingiva. So gingival is on the gingiva. And then subgingival is between the periodontal attachment and the gingival margin within the pocket. And then we have fissure biofilm, and that develops in the pit and fissures of the teeth. Okay, so the distribution of biofilm by surfaces during formation, the supragingival biofilm formation begins at the gingival margin and in the proximal surfaces, and then it increases rapidly when it's left undisturbed. So it spreads over the gingival third and on towards the middle third of the crown. The tooth surfaces involved occurs most frequently on proximal surfaces around the gingival third, and it's associated with protected areas. So they have to actually get in there and floss because those areas are protected. The least amount occurs where self-cleansing activities are effective. So think of toothbrushing. Where is it easiest to reach with your toothbrush? Those are going to be the areas that have the least amount. All right, so biofilm accumulation in protected areas, so crowded mandibular anterior teeth. Those are really hard to keep clean. And when we say protected areas, that's not a good thing, right? These areas are protected by other elements in the oral cavity, whether it's a tooth surface or gingiva or what, it's protected, meaning it's more difficult to reach. So you think of those the anterior crowding on the mandibular, it's really hard to get in there and clean that area. So it's protected, and you're gonna see more buildup in those areas. The thickest biofilm is on the proximal surfaces and the cervical thirds of the teeth, and that's because people are eating and often improperly brushing, so they aren't getting that more apical 1/3 or cervical third of the teeth. Note that the central incisors on the facial view and lingual view on A and B, with thick extensive biofilm on the less accessible and protected areas. So factors that influence accumulation could be crowded teeth, rough surfaces, difficult to clean. So under overhangs, under ledges of calculus, areas of caries, and then out of occlusion. So extended over the entire crown if the tooth is unopposed. So I had a patient one time that came in. He was a young man in his early 20s, and he had calculus even on the occlusal surface of his molar. The molar was unopposed. He had had a tooth extracted. And I said, what's going on here? Are you able to clean in that area? Because, it's covering the entire tooth. Like, he didn't have much calculus anywhere else in his mouth, but just in this little area. And here, the tooth had been bothering him, so he stopped chewing on that side. So he had plaque and calculus, quite a bit of buildup on that. I remember it was his left side. And it turns out he was brushing everywhere but in that area because it hurt. Well, if it hurts when he's brushing, it's also hurting when he's chewing. So he's also not eating over there. So there's nothing cleaning that tooth. So if you see one area that is, has a bunch of calculus in it, investigate why that one area, okay? And, often it is that the tooth has been bothering them, all right? And then bacterial multiplication, it's constant cell division. All right, so detection of biofilm. So you're going to use direct vision. You can see thin biofilm. You can see stain, whether it's yellow, green, or tobacco. You can see thick biofilm. It's dull, dingy, and fur-like surface. So you're going to use an explorer or probe, and you're going to do a tactile. So tactile is like the vibrations you get. Tactile is feeling, and you're going to get like little vibrations in the instrument when you're going over rough areas. So tactile examination is going to be slightly rough or slippery. Removal of biofilm presents when sliding the probe over the tooth. So you can actually remove biofilm because these are soft deposits. Okay, so clinical aspects, we're continuing our discussion of how to detect plaque, and we can use disclosing agents. And the biofilm takes on a color and becomes readily available, or readily visible, I should say, and cannot be used until the evaluation of the oral mucosa and gingival color has been recorded, because it can stain all of that. So you would do this after your intraoral exam. You're going to record the location and extent. You want to be specific, have specific details. I know that says specific, but specific details. You want to use an index to document the percentage. and then you want to keep that for comparison for their next visit. We do take a plaque index at every single appointment. Even if you started the cleaning last week and now you're finishing it this week, you're still taking a plaque indice at every single appointment, okay? Because it is a high risk factor for both dental caries and gingivitis, right? And inflammatory periodontal disease. So it's really important that we keep track of, is this patient improving or are they getting worse? And how can we help them? So I just want to make a little note here. I'm going to circle number 7 here. And you can kind of see how dark pink that is and how like some of the incisal thirds are a little lighter pink, like this area here. And so that is acquired pellicle, and then this is biofilm, that darker color. So significance of dental biofilm, it plays a major role in the initiation and progression of both dental caries and periodontal infections. Periodontal disease and caries are infectious transmissible diseases. Let me say that again. Periodontal disease and dental caries are infectious transmissible diseases caused by specific pathogenic microorganisms found in the biofilm. So any contact with somebody else's biofilm, whether it be through kissing or using the same utensils, can be transferred. Now we do have a window of infectivity. For caries, it's generally the primary caregiver's bacteria during that window of infectivity, which is 6 months to 36 months of age. So that's when mama's kissing the baby, or the caregiver, papa, whoever is kissing the baby and spreading that bacteria from their mouth to the child's mouth, and then the child takes on those bacteria, okay? But that can't happen until teeth are present in the mouth. So that's why it's 6 months to 36 months, okay? That's when their bacterial flora is forming in their oral cavity. But periodontal bacteria, they still haven't figured out the window of infectivity for that. Significant in calculus formation, calculus is mineralized biofilm and harbors bacteria. It's kind of like a honeycomb. Bacteria can go, it's very porous, so bacteria can go in and out of there, mainly in, and it locks in there, hardens, and it just continues to grow. Displaced gingival, it will displace gingival tissues, allowing bacteria to migrate subgingivally. Oral cleanliness depends on daily removal of biofilm. Dental caries is a disease of dental calcified structures such as enamel, dentin, and cementum. Microorganisms in biofilm, strep mutans, you have to know these, strep mutans and lactobacilli. Strep mutans and Streptococcus sobrinus and other acid-forming bacteria are initially the etiologic agents, and then lactobacilli have a role in the progression of the carious lesion. So you're going to see that in the bigger cavities. pH of biofilm depends on how much there is in there, but the more biofilm you have, the more acidic the mouth is, because those bacteria are releasing their byproducts that create acid. The carious lesion is characterized by demineralization in the mineral component and dissolution of the organic matrix. So here's a chart of how dental caries is formed. You're going to see cariogenic foodstuff, then biofilm formation, which then causes an increase in the pH and acid formation, and then it forms immediately. Frequent exposures to the tooth surfaces, to acid is going to lead to that leaching out of the minerals of the tooth, and demineralization is going to occur, and left untreated, it will turn into a cavity. Find this in your book. You are going to want to put this on your project that is due later this month. That's a huge part of your grade. This is one that you will want on there. All right. Dental caries, microorganisms, and biofilm. We're looking at strep mutans and Streptococcus sobrinus. And other acid-forming bacteria are initially the etiologic agents. Lactobacilli have a significant role in the progression. Decreased salivary flow, xerostomia, and increased dietary carbohydrate promote growth of strep mutans, streptococci, and lactobacilli in biofilm. Okay, so decreased salivary flow, or xerostomia, and increased dietary carbohydrates, such as your sugars, promote the growth of strep mutans and lactobacilli in biofilm. So here's a pH chart. The pH of biofilm. Acid formation begins immediately when the karyogenic substance is taken into the biofilm. The pH of the biofilm is lowered promptly, and 1 to 2 hours are required for the pH to return to normal. pH before eating or drinking ranges from 6.2 to 7.0. And remember, 7 is our neutral, right? Immediately following sucrose intake into biofilm, a rapid drop in biofilm occurs. So the critical pH for enamel demineralization averages from 4.5 to 5.5, but the critical pH for root surface demineralization, you guys put this in your little board study book, okay? You have to know both of these. Root surface demineralization is 6.0 to 6.7. So what I want you guys to think about is, as a person is sipping on their coffee, like me, throughout the day, it's important for them to also take swishes of water to neutralize their mouth, because that's leaving their oral environment exposed, or in more of a critical pH level. Okay, so if I have a cup of coffee every day, if I come in and I'm your patient, I say, I love my lattes. Okay, I absolutely love them. I will never give them up. What advice are you going to give me, okay, to maintain my oral health? One thing you want to say is, that's fine, have your latte. Try not to sip it all day, because every time you take a sip, the pH in your mouth drops, causing it to be more acidic, which then breaks the enamel down. Okay, plus it has some sugar in it. If I don't get the Northern Light latte, it has some sugar in it, and that is now going to be 2 components that are contributing to decay in my mouth. Okay, so it's better to drink it in one sitting than to sip on it all day, never letting your oral environment recover from that first acid attack. Okay, because it takes 1 to 2 hours for it to neutralize again. Well, if I'm taking a sip every half hour, it's staying in that high acidic environment, just bathing my teeth in acid. All right, so the pH of biofilm, amount of demineralization depends on the length of time and frequency in which the pH is at or below the critical pH. Frequency, length of time. You need to know those two. This should be discussed with the patient. So you can see in this, so they eat breakfast, the pH drops, okay? Then it comes back up, they eat lunch, and it drops back down. Where if I'm trying to find a place, I can't find my pen on here. Here we go. Okay, so say I have my coffee. Actually, I'm going to write it down here on top of this. I'll use a red pen. Red. Okay, so say I have my coffee, and my coffee represents the red, okay? So my oral cavity is neutral. I drink a sip of coffee. And then right away I take another sip. Okay, and it hasn't recovered yet, so I'm here. And then I take another sip, and I'm sipping on it for hours. But do you see how I never really get up above, back to that neutral area? See how much time I'm spending below in that critical pH area? That's what happens when you're sipping throughout the day. All right, dental caries, the carious lesion. Incipient carious lesions begin as a subsurface demineralization. Acid from bacterial action on the tooth surface passes through the microchannels in the enamel and demineralization occurs. And eventually a white spot can be seen. Early and continuous use of fluoride for demineralization is necessary. So we have fluoride in toothpaste, we have fluoride in-office applications, we have prescription fluoride, we have all sorts of options depending on that patient's needs. Okay, I think I'm going to stop here and create another video just because these are getting a little bit long, okay?